Hello, my name is Naomi Valadez, and today I'm going to talk to you about my reflection and perspective on the reading this week. And we're going to start with the first question: what are the main points on these readings? And these three articles reveal that migration is not merely a matter of phenomenon, but a public health determinant and shaping who gets sick and when and how survive. One core idea across all the six is that infectious disease is really shaped by mobility patterns and particularly by how well or poorly health systems address the vulnerabilities and create immigration. And the articles by Williams emphasize that infectious disease among the immigrants in the USA are often linked to both the pre-migration conditions, like endemic TB or ICB, or in origin countries, and post-migration factors such as overcrowded housing, legal status, and discrimination. And this lack harmonized health data that migrants receive the service across Europe results in the black spots that had affected the prevention and care. And Martinez and another article take this further by showing the age, phase of migration like the pre-departure, transit, destination, reception, and return, and presents distinct health risks and opportunities for intervention. And their findings, such as that exposure to ICP prevention usage is sharply declines after departure, and despite the being possibly associated with ICP testing is a vital behavioral prevention. And Lynch and Rapper expands its links global efficacy on the transit migration within Africa, and show with that how the asymptomatic carriers of malaria, especially in the drug resistant strains, can sustain the spread of infection across the past regions. And migration corridors and the national borders. And this one can be determined at the spread. And together, the stress are takes to reach the health systems to adopt a dynamic, fit-sensitive, and conceptually grounded response. They actually highlight the need of integrating epidemiology with the social science, policy, and ethics to understand and address infectious disease among migrants. Continue with the second question: was anything empiric confusing to you and why? One concept that left me reflecting deeply is and a bit complicated was the role of the public health surveillance in migration. And the Williams article did a strong synthesis of the need to be better surveillance systems that disaggregated the data by migrants' studies. And this makes sense epidemiology when we need good data to design a good policies. But it also raises ethical and practical concerns. Can we surveillance ever be truly neutral in the context where migration itself is criminalized or policies? And can migrants choose that information collect won't be used against them? And similarly, in the article by Martinez and Nanan, demonstrate that prevention and message effectively encouraging the ICB testing, but also show that exposure to these messages is increasing the high-risk phase like transit underplantation. And why is this happening when these moments are exactly when support is most needed? And it makes me question how well and the prevention of the campaigns are adapted to the realities of migration. And are we falling to racial people precisely when they are most vulnerable? In ethical coalition report, the discussion of malaria drug resistance is spreading through the migration also introduces some uncertainty for me. This article explains that how people moving from high to low transmission areas can trigger the local outbreaks. But what remains unclear is how these movement patterns can be tracked in the real time, especially in areas with the porous borders and little infrastructure, and if we don't have timely data on this transit migration. Can we prevent this growing resistant malaria from still expanding? And these tensions between surveillance and trust and data analytics and theory and real-time practices highlight the complexity of the work, the intersection of migration and infectious disease. And they challenge me to think more about critically about how global health must account not just for pathogenists but for political sphere and systemic silos. Well, continue with the third question. I was need to understand how you think about or perceive things. What really changed my perspective was the realization that disease prevention and cannot be confined to the borders of national systems, and it must be fluid, just like migration itself. And before reading these articles, I have a fairly traditional view of the public health that actually is bringing a treatment issue effort of the entry points or within national health systems. But Martinez and Anand relate the health behaviors like ICB, testing and shaping across all phases of migration and not just at a destination. And I hadn't fully understood how deeply and vulnerable the migrants begin in transit or at intersection phases when prevention measures and care of and often absence. Another powerful realization comes from the legislative report on malaria transit and migration in Africa. I was surprised a lot to learn that migrants, especially those asymptomatic and systemic resistance to malaria, and the lineage from the US across regions is spreading the infection silently. And this helped me to understand that migration is not just a movement of people, but also movement of pathogens, genes, and the resistant patterns. And I have not previously connected to these dots between the population movement and the global evolution of the drug resistance. And the wellness article out the European context I also hadn't considered, and the many infection diseases in the top five migrants are not acquiring host countries, and they are a result of complex long-term health inequalities and lack of access to early care. And this shift in my perception from thinking of migrant health as a new arrival issue to saying of the continue of the race inequality on island. And also make me reflect on the limits of our health system when it comes to diseases. Now, as a field physician, I see infectious disease among the migrants and all that doesn't be a medical challenge, and but also a structural, ethical, and logistical issue that as article has shaped in the whole I think, and about the responsibility that we have, like that we can claim to practice a global health and prevention strategies to stop at borders. Okay, continue with the first question. Was there anything you would like to explore further and learn more on what and why? Well, yes, this brings up on me what area of inquiry that I am not eager that appreciate. And for example, how to operate international migrant sensitive infection disease strategies across the multiple systems and borders. And the article by Williams have highlighted how the USA lacks a standardized coordinated screening strategies. And that made me wonder, how do the countries with different health infrastructures and migration policies and political claimants collaborate to deliver the core and continuous care to the people on the move? And I'm especially interested in the concept of the transnational public health programming, like the binational IGB prevention, as first mentioned by Martinez and Donate in our article. But for example, their study of Mexican migrants shows exposure to prevention message sharply drops after the living home communities. And why can prevention campaigns travel with migrants? And could we build portable digital prevention tools that work across the borders? And how this could international consortia coordinate target the messaging and screening in real time. Another area I'm actually interested in and I want to explore is policy innovation at migrant interception points, such detention centers and deportation stations. And these are often high-risk environments where the people are medically neglected, and they could also be powerful moments to intervention if I design it ethically and humanly. How are NGOs or mobile health units navigating these spaces? And finally, the Lynch and Roberts focus on malaria made me curious about how resistance surveillance works in the under-resourced areas. And do we have the tool to track the pattern and evolution across the migration routes in real time? And if no, we have it, innovations, whether molecular, technology, or policy basis, are need to get there. And these questions matter deeply to me because they see that intersection of clinical care, public health, and human rights. And I want to be part of one of the system where care that travels with people and not just waits for the time of the border. Well, continue with the last question. Give at least one specific example of an aspect of your experience in your personal or professional life that relate to the main topic. Well, during volunteer work, I encountered a group of Central American migrants who had been traveling to the north for a bit weeks, and among them was a young man that actually cursed with fever, chills, and pain muscle, but had no actually a diagnosis at the time. And initially we suspect to dengue for the weather, but in that, after learning that have recently passed through the malaria endemic zones in the southern Mexico or maybe in the northern of Guatemala, we realized it could also be malaria, and a diagnosis that wasn't even our initial checklist. And I think it's more like for no knowledge. And that moment, it made me realize how disconnect we have with the care algorithms are from the migratory realities, and we have to diagnose it by geography, but migrants are the five fixes of geography. Their symptoms reflect the place they pass through, not just where they are now or where they come countries. This case makes me see the critical importance of taking the migration history and your clinical history and updating the clinical mindset to reflect the pattern and pathways and not just the national borders. And especially this type of patients that are actually migrants are, in Mexico is not too common to have malaria, but we live in the zone with the Central America have some. It is like a zone endemic of malaria, and it's a diagnosis we can need to have it in mind. And later then, we learned that have been infected maybe with Plasmodium vivax, a strain not often found in northern Mexico, and that's because the awareness is alleged a role per an article, and this transit of migrants can become mobile reservoirs for infection, and not by fault on their own, but because the physician fails to the media along the way. And this spreads also make me reflect with the article with Martinez and Donate that none of the migrants we traded with a single HIV prevention messaging weeks, how many didn't know how were they get tested, and they were in transit and visible to the system, and that memory has stayed with me and follows my commitment to bringing the current to the between spaces and not just calling hospitals but borders, roadsides and shoulders.